Uh, good morning. Today we will have a case discussion on obstructive jaundice. Dr. Hari Prasad is a third-year junior resident at South Eastern Hospital will present the case, and Professor Shivojyoti Ghosh, Professor of Surgery at Calcutta Medical College, will moderate the session today. I will be there. So, Dr. Hari Prasad, you can share your screen and start presenting, and wait at the end of history. We will have some discussion history part, and then go to the examination, and then proceed on to the diagnosis and management. So, start. Hari Prasad, you can start.
Dr. Hari Prasad, you're muted. Dr. Hari Prasad, you're muted. Can you please unmute yourself?
Sir,
You're audible now. Yes.
yes, sir. So, do my screen visible, sir?
Yes, your screen is visible.
Your
Yes, sir.
screen is visible. Yeah. Now your PPT is also visible.
Yeah. Yes, yes.
The patient profile: a 66-year-old lady, resident of Kharagpur, housewife by occupation, belongs to poor socioeconomic status. The known case of hypothyroid. She came with a complaint of yellowish discoloration of skin, urine with clay color stool passage, and generalized itching all over the body, anorexia and loss of weight for past 2 months, not associated with vomiting, constipation, hematemesis, fever, or altered bowel habits. The patient was apparently normal before 2 months, after which she had anorexia, loss of weight, around 10 kg in 1 month, associated with progressive yellowish discoloration of skin, sclera, and urine for past 20 days, associated with black tarry stool passage initially, which later turned to clay colored stool passage for past 20 days, associated with weight loss of around 10 kg in the past 2 months, not associated with fever, hematemesis, altered bowel habits, or urinary complaint. So, past history: she is a known case of hypothyroid and under tablet thyroxine for around 10 years. No surgery history, no surgeries underwent in the past. Personal history: she is married, postmenopausal, no history of any postmenopausal bleed, no addictions, normal sleep-wake cycle, takes mixed Indian diet, and bowel and bladder habits are normal. Family history: no history of any malignancies in the family. Case summary: it's a 66-year-old lady, came with a progressive painless jaundice with anorexia and weight loss, generalized itching all over the body, and the passage of clay-colored stools for past 20 days, not associated with hematemesis, vomiting, or altered bowel habits.
Hari Prasad,
Yes, sir.
we will have some discussion on the history part. I think it became very, very concise. It should be a little more. Dr. Ghosh, we can go to the first slide.
Yes, sir.
Next. Yes, sir. This is a chief complaint I like to mean. So,
Yes,
so
sir.
many things with so jumbled up. It's not required. Chief complaint should be clear, one
Yes, sir.
sentence of one symptom, and
Yes,
then
sir.
the duration. You need
Yes,
not
sir.
bring everything into this vomiting, constipation, hematemesis. These are not all chief complaints.
Yes, sir.
So confine to one particular symptom with a
Yes,
duration,
sir.
maybe 1, 2, or maximum 3, not beyond that.
Yes,
And
sir.
then come to history present list. Take each of
Yes.
these chief complaints. Dr.
Yes,
Ghosh,
sir.
your comment.
That is
Muted. Dr. Ghosh, you are muted. Yes.
Yes. So you see that rather you have repetition of the same things, chief complaints and history of present illness. Same things has been there is repetition. So as Professor Saha said, the chief complaints should be in a few lines or sentence, and in the history of present illness, you're supposed to elaborate those complaints.
Yes,
So
sir.
that is the I mean the ideal way of presenting the history. And at
Yes.
the end, you have written case summary. Case summary is at the end where you give the summary of the history as well as your clinical findings. Here you can
Yes, sir.
write the summary of the history, right?
Yes,
At the end, you can say summary of the history so that we can decide which system should be examined thoroughly and should get priority, right? So
Yes.
instead of case summary, you should write the summary of the history. Okay.
Yes, sir.
And as sir said, it should be more elaborate.
And,
Yes, sir.
and then you start in the history, go to history of present illness.
Sure.
You see, basically you are dealing with a patient who has got yellowish discolored eyes and urine.
Yes, sir.
And from the history, we will like to make out whether this jaundice is number one obstructive, whether this patient has got a preceding symptoms or prodromal symptoms. You are not sure at this stage, it's a surgical jaundice or medical jaundice. So you should give detailed history about the jaundice first.
Yes, sir.
What happened preceding the history of jaundice?
Yes, sir.
Did this patient has any prodromal symptoms? If no, you say there is no prodromal symptom preceding the onset of jaundice. I exclude
sir.
viral hepatitis.
Yes, sir.
You can
Fever.
start with patient does not have any history of colic preceding the onset of jaundice. That
sir.
indicates a stone disease causing jaundice.
Yes, sir.
So
And
then
fever.
study the jaundice. Don't bring everything in the same line.
Yes, sir.
Especially black studies too, that come afterwards. You first give a paragraph spent on the jaundice, insidious onset of jaundice, which is gradually progressive, and you said if patient has got black tarry stool. If patient has got black tarry stool, sometimes there is some diminution of this intensity of jaundice. You mentioned that. That has some message to give, whether this is an ampullary tumor or it's a peridural tumor. So these are the things, a point in favor of your diagnosis.
Yes, sir.
And then come to the other associated symptoms like
Yes, sir.
itching, clay color stool. This elderly lady having a situation of obstructive jaundice, now you should go to the symptoms from where you can make out the etiology.
Yes, sir.
Is it a malignant jaundice or benign jaundice you feel?
So it's a malignant jaundice.
If it is malignant jaundice, you try to find out.
Yes, sir.
If it is a carcinoma in the head of the pancreas, patient may have associated gastric outlet obstruction. He
Yes, sir.
did not mention anything about that. Whether patient has
Sir, vomiting.
sensation of fullness of vomiting may not be always there.
Yes, sir.
The initial symptoms of outlet obstruction is sensation of fullness after meals,
Yes, sir.
discomfort after meals, and then vomiting. So what I'm trying to say is, you pick up each of these. If it is a malignant jaundice, it is a localized disease, or patient has got some evidence of spread.
Yes,
That
sir.
can you make out from the history.
Yes, sir.
If the patient has got any distension of the abdomen,
Yes, sir.
patient has got any bone pain, patient
Yes,
has
sir.
got any history of chest pain, cough, hemoptysis, everything comes, so that you can make out that clinically, history-wise, patient does not have symptoms, history of distant metastasis.
Yes, sir.
Okay, Dr. Ghosh, I think
Yes.
history should be a little more better written.
Yes, sir.
Right.
Sure.
So from this history, so you should keep in mind the probable diagnosis. So if your diagnosis if you think this could be a case of periampullary carcinoma, I do think progressive jaundice is a typical feature of periampullary carcinoma.
Yes, sir.
Typical in how many percentage of cases is it typical?
So more than 50.
Yes.
So more than 50% of the periampullary.
No, around
So
30%.
Usually intermittent jaundice or fluctuating jaundice is a classical history of periampullary carcinoma, right? That is present in 30 to 40% of cases. And you said patient has a history of one episode of melena, right?
Yes, sir.
So usually this patient, when there is fluctuating jaundice, what is the cause of fluctuation of jaundice in periampullary carcinoma?
Sir, the biliary tree is not completely obstructed. It is partially obstructed.
No, that is not the cause for fluctuation. Fluctuation see, if it is not obstructed, the jaundice degree will not be that high. Fluctuation is because that tumor is growing.
Yes,
And
sir.
if it is a proliferative growth, at one point in time, the growth slaps off.
Yes,
This
sir.
can happen in the duodenal carcinoma adjacent to the ampulla. This can happen in the ampullary tumor. This can happen in the cholangiocarcinoma with a papillary pattern.
Yes,
It
sir.
will not happen in a carcinoma head pancreas with two cell ampulla.
Yes,
So you
sir.
have to keep in mind in which situation the jaundice can fluctuate.
Yes, sir.
There is sloughing of tumor that leads to melena,
Yes.
and consequent to that, there is some diminution of jaundice. Jaundice may not be relieved completely.
Yes, sir.
Right. So there will be fluctuation of jaundice and there will be history of intermittent melena. Now, if
Yes.
you get a single episode of melena in this patient, so what are the other possibilities regarding the source of melena you should keep in mind? The common possibility.
Sir, can be the tumor perforating into the gastroduodenal artery.
No,
If it
you
is-
should not think, the rare conditions, common things. Patient may have associated tonic dural ulcer, you never know.
Yes, yes, sir. Yes, sir.
Right. So while you examine this patient physically, so you should always try to see the epigastric region if there's any tenderness or not.
Yes,
Or
sir.
also you should ask about the past history of patient, if the patient has any past history of history related to chronic duodenal ulcer. Right.
Yes, sir.
So these are the things from history you have to elaborate. Right.
Yes,
If
sir.
you get a single episode of melena, then this thing you should keep in mind.
Yes, sir.
And chronic pancreatitis is a risk factor of the carcinoma pancreas. In the
Yes, sir.
past history, it should specifically mention before the onset of jaundice whether she has got any history, chronic history of pain, which may suggest chronic pancreatitis. These are the things one should be mentioning. You specifically mention whether she has any history of diabetes and she's still diabetic or not, because there is some association between diabetes and carcinoma pancreas. Okay, so in the history, you see, obstructive jaundice is a very important case, and the history should be so nicely said so
Yes,
that
sir.
examiner can have a lot of questions out of the history.
Yes, sir.
So, and one more thing, when you see a patient, say, don't get biased that you are just looking into the periampullary carcinoma, right?
Yeah.
Suppose in a case of carcinoma of the breast, so just don't focus on carcinoma of breast also, only because you'll have to have a overall, you should keep your eyes and ears open, right? This patient may have other associated disease, other problems, right?
Yes, sir.
So these has to be incorporated into your history, because if when you operate on this patient, you will have to take care of all the diseases. You just can't treat periampullary only. If the patient is having, say, past history of chronic duodenal ulcer, right? So you got to make sure that this ulcer has healed or there is no further complications related to ulcers. Okay. So similarly, in other, say, carcinoma of the breast, the patient may have some associated other problem also. So in history, you should keep your mind open.
Yes, sir.
This can be a jaundice because of an excessive compression in the bile duct.
Yes,
It can
sir.
be a primarily CS stomach. You said melena.
Yes, sir.
It can be a CS stomach with a lymph node metastasis.
Yes, sir. Lymphomatous.
It can be chronic pancreatitis causing compression in the bile duct. So don't be biased with the diagnosis. You keep to your points in history. That means you keep on asking about the jaundice, keep on asking about other symptoms of GI tract, ask about any history of metastatic disease in the other systems.
Yes, sir.
And then pass on to the next part.
Yes,
so that gives a complete history.
Yes, sir.
Okay, next.
Pass on to the examination.
So, survey, the patient was conscious, alert, oriented, cooperative, and well hydrated. The ECOG score of 2. The patient was average built, icteric, pallor, and the BMI of 19 kg per meter square. No cyanosis, clubbing, lymphadenopathy, edema, dilated cervical veins seen. Multiple scratch marks seen over the body. Pulse rate is 86 per minute. Blood pressure is 112 68 millimeters of mercury. Sir, abdominal examination. On inspection, the shape and contour of the abdomen normal. Umbilicus normal in position. No visible dilation of veins. Scratch marks seen over the abdomen. All quadrants are moving equally in respiration. No visible peristalsis or pulsatile movement seen. No visible swelling over the abdomen. Hernial sites, no visible swelling, and the external genitalia was normal. On superficial palpation, the palpable lump over right hypochondrium extending to right lumbar region, non-tender, soft and elastic, and there was no warmth. On the deep palpation, the gallbladder was palpable over the right hypochondrium, extending to right lumbar region of size around 4 into 3 centimeter from the right costal margin in the midclavicular line. Globular shaped, smooth in surface, well-defined lower, medial, and lateral margins are palpable. Upper margin was not palpable and passes deep to the costal margin. Firm in consistency, intra-abdominal on leg raising test, and the swelling moves up and down with the respiration, and the swelling was not fixed to the skin. On percussion, dullness felt over the lump, and the upper border of liver dullness is at 5th intercostal space over the right midclavicular line. No free fluid in the abdomen. On auscultation, bowel sounds normally here. Rectal examination, clay-colored stool present. No palpable mass. And systemic examination, other systemic examination like cardiovascular, respiratory, and the central nervous system, all are within the normal limits. Sir.
Wait. Don't go into investigations.
Yes, sir.
Come on to the examination.
Yes, sir.
You see, why do you just make a one word of survey?
So general
Either you
survey.
say general examination or general survey, whatever.
Yes, sir.
Okay.
Yes, sir.
Why you say ECOG 2? What do you mean by ECOG 2?
Sir, ECOG 2 patient is ambulatory but not able to carry out the normal regular activities. More than 50 hours of the waking, total waking hour, more than 50% of the total waking hour patient is awake. And
so this indicates what? Early disease or advanced disease?
sir,
If you
early,
say patient fitness wise?
sir, early disease.
Early disease, ECOG 2. Patient cannot, 50% time patient is in the bed.
Yes, sir.
ECOG 2 is intermediate.
Yes, sir.
You cannot stamp that patient ECOG 2 as an early disease or patient is otherwise fit for your major intervention.
Yes, sir.
Okay.
Yes, sir.
Come to palpation. Inspection is all right.
Yes, sir.
If you say gallbladder is palpable over the right hypochondria, I mean PG level, you can say like that.
Yes, sir.
So if you say gallbladder is palpable, then
Yes,
it's no
sir.
point saying that it is intra-abdominal lump, it has got a medial border, lateral border, lower. It's implied.
Yes, sir.
If you can start your description with, there is one way of saying, people say it's a lump in the right hypochondria, action to this lumbar with this medial border, lateral border, lower border, upper border not seen, then you infer. You started with gallbladder is palpable.
Yes, sir.
So in that case, the lower points are redundant.
Yes,
If
sir.
you say gallbladder is palpable, you need not say separately is the intra-abdominal lump.
Yes, sir. Yes, sir.
You did not say that medial, lower, and lateral border are palpable.
Yes, sir.
So describe the lump.
Yes, sir.
A gallbladder lump that is palpable may be either a lump because of distension, number one,
Yes, sir.
or it is a lump because of some intrinsic growth in the gallbladder.
Yes,
How
sir.
do you differentiate? What is the difference between a gallbladder lump palpable because of a distal obstruction versus a gallbladder lump which is palpable because of underlying growth in the gallbladder itself? Is there a difference or the same?
Sir, generally, according to core process law, gallbladder is not palpable unless if it has been periampullary CA, there is a distal obstruction. Because if it is due to gallbladder, it will be a fibrous gallbladder, it won't be palpable.
No. I asked a different question. I asked the gallbladder is palpable.
Yes, sir.
So examine the gallbladder. Can you say this is the gallbladder palpable because of a distal obstruction? That means the gallbladder is distended.
Yes, sir.
Or there is a growth in the gallbladder and gallbladder became palpable. So is these two palpable gallbladder same clinically?
Sir, no, sir.
What?
Sir, if it is because of,
Consistency. How is the consistency of these two kinds of gallbladder?
sir, if it is distended because of any distal obstruction, it will be firm in consistency. But if it is due to a growth, it will be hard in consistency. Of
And
palpation.
what about the surface margins?
Sir, here the surface and margins will be smooth, but in case of a growth, the surface will be irregular.
So that is the thing you should describe. In examination, once you say gallbladder is palpable, we are interested to know what is the character of this palpable gallbladder.
Yes, sir.
Which will indicate that it's a distended gallbladder or it is a gallbladder because of, you see, even in some carcinoma gallbladder, palpable gallbladder is not very common.
Yes, sir.
Okay.
Yes, sir.
Okay, next.
And one more thing, this gallbladder usually we don't describe is at globular. Usually we say a pear-shaped or elongated, right?
Yes, sir.
Usually not globular shape.
Okay, sir. Yes, sir.
Okay, next.
Yes, sir. The investigations.
No, don't come to investigation. You just skip to the clinical part. Now you summarize, give the diagnosis. You have not summarized at the end of examination.
Yes, sir.
You have to summarize at the end of examination, put a diagnosis. You don't need to about the investigation of this patient. We will be discussing the approach to this patient as a candidate. So how do you summarize this patient?
This is 66
Summary one paragraph from the history, one paragraph from the examination, and then give a provisional diagnosis. Just summarize.
Sir, this is a 66-year-old lady, known case of hypothyroid, came with a history of progressive jaundice, yellowish discoloration of skin and sclera, and generalized itching all over the body. And on abdominal examination, the GB is gallbladder is palpable.
Don't miss the patient is jaundiced. That is most important. Why do you in examination jump to the gallbladder palpability? In summary, you are supposed to say the salient points of the history.
Yes, sir.
And then self-examination. You say patient is ECOG 2. I
Yes,
consider
sir.
this patient is not ambulant all the time, not carrying out normal activities. That is also very important. These patients need to be prepared for surgery.
Yes, sir.
Patient is deeply jaundiced. Comment about whether she is anemic or not. Any edema. And then come to the abdominal examination.
Yes, sir. Sir, she's a 66-year-old lady who is came with a complaint of jaundice and ECOG score of 2 and associated with anemia and no peripheral edema. On examination,
Any lymph node in the neck?
no,
Any
sir.
lymph node in the neck? These are all important. You see, summary means you bring out the important points.
Yes, sir.
So that you can use this for the next question. The next question will be asked, obviously a simple question.
Yes, sir. So there was no cyanosis, clubbing or lymphadenopathy or edema or any dilated neck veins. Scratch marks.
Why dilated neck vein is important in summary? Just tell me. Why is the dilated neck vein important in summary? It's not relevant.
Yes, sir.
More so is a normal veins in the neck. So
Yes,
try
sir.
to make a good summary also. That is important.
Yes, sir.
Most of the time will be asked about the summary of the patient.
Yes, sir.
So make a good habit of writing good summary. One paragraph from the history, one paragraph from the examination.
Yes, sir.
Now, Dr. Ghosh.
Yeah, each and every word that you use in summary is very important. That should be logical, rational, and scientific, right? If you
Yes, sir.
if you write unnecessary, irrelevant words or sentences in a summary, so you will be inviting more unnecessary questions. Okay. So whenever you write your summary, you should think about the every word you say because you are likely to be asked questions on that word.
Yes, sir.
Okay. Next area. So what is your provisional diagnosis? After the history, summary of the history, usually we write down or speak
Yes,
about
sir.
the provisional diagnosis. So what is your provisional diagnosis of this patient?
Sir, obstructive jaundice due to periampullary carcinoma or CA head of pancreas.
No, you can't mix up everything.
Keep one diagnosis.
Sir,
And give us a
One.
complete diagnosis. You are examining, right? Examiners are assessing.
66-year lady.
yes,
Yes.
sir.
What?
Sir, 66-year-old lady. Sir,
Having obstructive jaundice, probably due to.
sir, obstructive jaundice probably due to CA head of pancreas.
You see, you said you should keep in mind what you said in history. CA pancreas usually does not come with melena. Once
Yes,
you
sir.
say patient has got a melena, I will keep more diagnosis towards a periampullary lesion.
Yes, sir.
Okay, you can put head of pancreas. I agree, but point is you should be sticking more to the closer diagnosis as you present it.
Yes, sir.
Okay,
Sir,
why do you say patient has obstructive jaundice? What are the points in favor of diagnosis of obstructive jaundice?
Sir, obstructive jaundice patient is clinically patient is icteric and associated with generalized itching, and the jaundice is progressive in nature, not associated with any viral hepatitis features like fever.
What
Don't
are
make
the
the
symptoms?
answer after that.
What are the symptoms of obstructive jaundice? Signs and symptoms of obstructive jaundice. Tell me 3 important signs and symptoms of obstructive jaundice.
Sir, yellowish discoloration of skin and sclera and urine.
Jaundice has to be there. Next.
Sir, clay colored stool passage.
Yes.
Sir, generalized itching all over the body.
Yes.
So these are the usual symptoms of obstructive jaundice.
And
Yes, sir.
number 3, intermittent fever, right, due to cholangitis. So,
Yes, sir. Yes, sir.
pain, I mean, itching, clay-colored stool, and intermittent fever with chills and rigors. So these are the classical 3 symptoms of obstructive jaundice. So not necessarily all 3 has to be there in your case. So either if one is there associated with the jaundice, so we can reasonably say this could be a case of obstructive jaundice.
Yes, sir.
Then why
Can you
do
give me Hari Prasad, can you give an example that patient has got viral hepatitis, but patient has got progressive jaundice? When it can happen?
Sir,
Fulminant hepatic failure.
yes, sir. Yes, sir.
So not always that progressive jaundice is always obstructive.
Yes,
Patient
sir.
who has got a viral hepatitis and
sir.
patient is going to fulminant hepatic failure will have progressive jaundice and failure.
Yes, sir.
Usually we talk of progressive jaundice on the background of a chronic obstruction.
Yes, sir.
And in the same time, as I said, you should ask about any prodromal symptom just before the onset of jaundice. Anorexia, malaise, joint pain, skin rash. So these are the few prodromal symptoms which maybe they are in patients of viral hepatitis. And what is the course of patient having viral hepatitis? If you take the jaundice and the prodromal symptom, what is the usual course?
Sir, of course, initially it will start with the fever and then it will lead to jaundice, sir.
It has got a anixeric phase, icteric phase,
Yes, sir.
and then convalescent phase.
Yes, sir.
What is that? Anixeric phase is the phase of prodromal symptoms.
Yes, sir.
Icteric phase when the bilirubin is going up.
Yes, sir.
And what is the usual duration? As I said, it's a natural course of viral hepatitis. How long this persists?
So 4 to 6 weeks.
No, 2 to 4 weeks maximum.
Yes, sir.
And then it goes down.
Yes, sir.
Okay.
Yes,
Now
sir.
this patient, you have not specifically mentioned whether this patient has got any colic. That you have to mention in history also. If the
Yes, sir.
patient, if the jaundice is preceded by an attack of colic,
Yes, sir.
that
Cholangitis.
might indicate patient has got a cholangitis or patient has got a suspected stone disease.
Yes, sir.
Okay.
Yes, sir.
Okay, so then the probable cause, what do you think about the probable cause of obstructive jaundice?
Sir, sir, right now with the clinical information, can be periampullary celiac, can be celiac of pancreas.
No, you'll have to stick to one.
Sir, I had written black tarry stool since because the patient had one episode, but actually this patient is a CA head of pancreas, sir.
How do you know it's a CA head of pancreas?
Don't get biased if the diagnosis is given.
Yes, sir.
Okay. You have to explain the clinical behavior. You may be wrong somewhere,
Yes,
but
sir.
you stick to your clinical presentation. Don't see that patient has got a CT scan in front of you which has shown this.
Yes, sir.
Then you have to explain this melena. As Dr. Ghosh said, patient may have other disease associated.
Yes, sir.
C-head pancreas as such doesn't come with melena. C-head pancreas with portal vein obstruction, portal hypertension, we
Yes,
have
sir.
melena.
Yes, sir.
But if you more closer diagnosis, periampullary tumor, this can be easily explained by the behavior of the periampullary tumor itself.
Yes, sir.
And then keep DD as C-head pancreas. Yes, all the time.
Yes, sir.
Just remember one thing, you should have your clear conception about the provisional diagnosis. The term is provisional, right? It is
Yes,
not
sir.
a final diagnosis. Okay.
Yes, sir.
So
Yes, sir.
when you are saying provisional, so provisional diagnosis may change in the course of investigations.
Yes,
So
sir.
if the provisional diagnosis changes in the course of investigation, that does not mean you are wrong in your provisional diagnosis. Provisional diagnosis is always made on the basis of your history and clinical examination.
Yeah,
Yeah,
not based
right.
on investigation.
So it's not based on the investigations. And what is the importance of having a provisional diagnosis? Provisional diagnosis is the one thing which will guide you on which direction you will go for the investigations. Nowadays, there are a lot of investigations and which are almost competing with each other. Whether you will go for MRCP first or CT scan first in this patient, that will be dictated by your provisional diagnosis. That will be dictated by your history and clinical examination. You cannot write all the investigation at a go. MRCP, ERCP, CT scan, US, all the investigation you cannot write. You have to justify, right?
Yes, sir.
So that's why it is important to make the provisional diagnosis on the basis of history and clinical examination. And from provisional diagnosis, you will decide which investigation will do first, right?
Yes,
That is the logic and that is the science and that is the reasons. Okay.
Yes, sir.
So don't look at the investigation, CT scan diagnosis, and then you come back to your diagnosis, right? Even the CT scan report can be wrong.
Yes, sir.
Okay. So now you tell us
Provisional
why
is
do you
up.
say it's okay. So what is your provisional diagnosis in this for this patient based on history? and clinical
6-year-old lady with obstructive jaundice, probably due to periampullary carcinoma.
Okay, but stick to this. This is a reasonable diagnosis in this patient.
Yes,
On the
sir.
background of gallbladder being palpable,
Yes,
which is smooth, firm gallbladder. So this is a reasonable diagnosis.
Yes, sir.
Okay. So now can you tell me one point from history by which you can differentiate between periampullary carcinoma and carcinoma of the head of the pancreas?
Sir, periampullary carcinoma may have clinical features like gastric outlet obstruction and
Periampullary, that is more common. Gastric obstruction more common in periampullary. You want to mean? Periampullary is around the ampulla.
Yes, sir.
Whereas carcinoma head pancreas in the whole celiac of duodenum. In which case outer obstruction is more common.
The head of pancreas.
Yes. Why do you make a reverse comment?
So in a typical case, it's not always true. In a typical case, in periampullary carcinoma, the patient will have jaundice first, followed by pain, because it is in the ampullary region which gets obstructed. So jaundice will be apparent. And
Yes, sir.
in carcinoma head of the pancreas, the patient will have pain first and other symptoms of malignancy like weight loss, anorexia, right? Then after say 1 or 2 weeks later on, the patient may have appearance of jaundice, right?
Yes,
So from this history, you can clinically you can say yes, this patient has got periampullary, or you can say yes, from the history you can say the patient has got carcinoma of the head of the pancreas.
Yes, sir.
Okay. Now you tell us what are you going to do next?
Sir, general blood parameters investigations we will follow like CBC, LFT.
No,
And,
don't start. Hari Prasad, this
Yes,
has
sir.
been discussed on a number of occasions in a MS or DNV examination. Don't start with the routine blood examination.
Yes, sir.
The approach is very clear. We already said in number of occasions. I'll do investigation to confirm the diagnosis.
Yes, sir.
Number 2, I'll do some investigation to stage the disease if you have a suspicion of malignant disease. And
Yes,
number 3, you do some investigation to assess patient fitness for anesthesia surgery. So these are the 3 groups of investigation. Don't
Yes,
start
sir.
with a routine blood CBC like this in this patient. So investigation to confirm the diagnosis,
Yes, sir.
investigation to stage the disease, investigation to assess patient fitness for anesthesia. So based on this, you proceed.
Sir, initially I will start with ultrasound. Ultrasound.
Why
of
not
the-
LFT? Why not LFT?
One
Sir,
second.
LFT.
Please repeat the word as Sir said. When you are asked the question, what are you going to do next? As
Yes, sir.
Sir said, just mention this point. First, I want to confirm. I want to do the investigation for confirmation of diagnosis, for staging the disease, and for fitness of the patient. So please utter these words. So that makes impressive, answers. Please tell these points before you say I will do.
Repeat. Hari Prasad, repeat. How will you proceed?
Sir, to confirm my diagnosis, initially I will go
No,
with the
just
liver-
outline. Investigation to confirm the diagnosis, number 1. Number 2, investigation to stage the disease. Number 3, investigation to assess his fitness for anesthesia surgery.
Yes,
So
sir.
there's the 3 broad headings.
Please
Now
repeat,
come to the first part.
repeat the words. Repeat the words. Right. That is important. That is your mock test. Repeat the word as Sir Professor Shah said.
Yes, sir.
Repeat these words. These are the things examiner will love to hear.
Yes, sir. For confirming my diagnosis, sir, I will start with liver function test
Yes.
and liver function test and we prothrombin time and INR.
Yes. Next. Just
Yes.
outline the investigation. We'll come to this, each of these.
Yes, sir.
Liver function test, including a PTINR. Next.
Yes, sir. Sir, sir, ultrasound whole abdomen as an initial
Okay.
investigation.
Next.
Yes, sir. Sir, to stage the disease.
Next, your answer should be, I like this answer.
Yes, sir.
My next investigation will be based on the ultrasound finding. You understand? We have
Yes,
given
sir.
a provisional diagnosis, and ultrasound is a very good investigation for hepatobiliary tree.
Yes, sir.
Ultrasound is an investigation which can help in diagnosing many things, and sometimes it's a stone disease. The investigation may be the end of it.
Yes, sir.
So your next investigation, you cannot jump to say MRCP or CT.
Yes, sir.
Here you will say, sir, my next investigation will be guided by my ultrasound finding.
Yes, sir. Yes, sir.
So you said LFT. What are the characteristics of LFT which will suggest obstructive jaundice?
Sir, the direct bilirubin will be more elevated on comparing with the indirect bilirubin. And the liver enzymes are elevated.
All liver enzymes elevated. If you make an unspecific answer like this, it is not
alkaline,
correct.
the alkaline phosphatase will be elevated much more.
What about ALT and AST?
Sir, will be elevated, but not the fourfold increase from the
Yes.
normal.
In a patient who has got early obstructive jaundice, ALT, AST may not be elevated.
Yes, sir.
If they are elevated to the borderline extent, not like
sir.
viral hepatitis, the tune of 5,000 or 6,000.
Yes, sir.
GGT may be elevated.
Yes,
Yes, sir.
if AST and ALT is elevated along with the elevated ALP, then
Yes, sir.
how do you going to interpret this LFT report? And the patient has suppose your diagnosis of periampullary carcinoma. So for your management is concerned, how this investigation will affect your management?
What does it implies?
Sir, whether the liver condition is.
So that indicates there is some hepatocellular damage.
Yes, sir.
There is some hepatocellular dysfunction.
Yes, sir.
Right. So you cannot take up this patient immediately for the operations, right?
Sir, we need to
Patient
clear
has-
it by ERCP and then we have to proceed.
No, wait. Don't jump to ERCP now. We are not going to that. The point is, this indicates patient has associated hepatocellular dysfunction. That may be for a number of reasons, maybe dehydration, maybe sepsis. So there are a lot of things coming up. So don't jump there. So now you said ultrasonography.
Yes, sir.
In this patient, you said, based on your clinical diagnosis, different things you can make out in ultrasonography. They're very important. Just give the points in ultrasonography which may help in your further proceeding in this patient.
Sir, GB is well distended and we will have a dilated cystic, dilated common bile duct, dilated CHD and dilated IHBR. And we also see a hypoechoic mass over the head region of the pancreas.
What else? So many things to come up in ultrasonography.
What are the other associated findings that we can have from ultrasonography?
What about
Sir,
pancreatic duct?
hepatomegaly, splenomegaly is there or not?
No, don't jump there. Be in the hepatobiliary area. What about pancreatic duct?
Yes, sir. Yes, sir. Yes, sir.
What
Pancreatic.
about any other, apart from IHBR dilation, anything else in the liver? Any comment about the lymph nodes?
Sir, any
Any
hypoechoic?
comment about the ascites? Any
No, sir.
comment about any other peritoneal mass? So they're all very important.
Yes,
It
sir.
may not be a complete diagnosis at the end of ultrasonography, but there are a lot of things one should look for in ultrasonography.
Yes, sir.
Don't just confine only to the gallbladder and the bile duct itself.
Yes, sir.
What is double duct sign?
Sir, when there are both pancreatic duct and the common bile duct get dilated, double duct sign. Because
What is the implication?
Sir, obstructive in case of head of CA pancreas.
No.
It cannot be in periampullary.
Yes, sir. It can be in periampullary.
So indication is there is an ampullary obstruction.
Yes, sir.
The implication is there is obstruction in the ampullary region causing dilation of both bile duct and the pancreatic duct.
Yes, sir.
So you have some clue to the diagnosis.
Yes, sir.
Can you tell me how the common bile duct and the pancreatic duct joins and opens into the duodenum? If you know this point, then this double duct sign implication will be clear to you. Where does normally this pancreatic duct and that common bile duct joins?
There are ampoule of water.
Yes, it is in the wall of the duodenum.
Yes, sir.
Right, in the wall of the duodenum, both the ducts joins and they forms the ampulla. So if there is obstruction at that level, then both the ducts will be dilated.
Yes, sir.
Right, that is an early sign for the periampullary carcinoma. Whereas in carcinoma head of the pancreas, initially the lesion will be small. Then the lesion has to be big enough to obstruct the ampullary region. Then there might be a double duct cell.
Yes, sir.
Okay. Then
So I'll give it ultrasound diagnosis. Ultrasound has said bile duct and PD is dilated, but
sir.
no obstruction could be delineated, no lymphadenopathy, no mass could be seen in the ultrasonography examination.
Yes, sir.
No ascites, no limbal enlargement seen.
Yes, sir.
Liver, apart from ISBI dilation, there is no other abnormality in the liver.
Sorry.
What should be your next investigation? I give you the ultrasound diagnosis in this patient. What
So
do
my
you think?
next,
What do you think at this stage? If this ultrasound finding, what
yes, sir.
may be the possibilities at this moment?
Sir, sir, with pancreas, sir, with double duct sign.
Yes, I said.
Yes,
PD
sir.
dilated,
Yes, sir.
common duct dilated, no mass could be seen,
Yes, sir.
no lymphadenopathy, no stone seen. So at the end of ultrasound, what should be your focus of attention?
Sir, it can be,
It should be a small, periampullary lesion.
yes, sir. Yes, sir. Which is non-directable.
Yes, not even the ultrasonography. That is the scenario I've given you.
Yes, sir.
It can be anything in the exam. Examiner can give you a different scenario also. But the scenario I've given you that indicates there is an obstructive lesion at the region of ampulla.
Yes,
But
sir.
ultrasound has not been able to pick up any mass lesion.
sir.
So what
Sir,
should be your... Yes, Dr.
sir.
Ghosh.
yes, next line of investigation in such a scenario, as sir has said.
The CECT pancreatic protocol.
Okay, we usually called MDCT, multi-detector CT,
Yeah.
or triphasic multi-detector CT.
Yes, sir. Triphasic.
Right. So, what are the things?
What are the different phases? You say triphasic. What are the different phases?
The pre-arterial, arterial, and the venous phase.
Pre-arterial means you should take a plain CT first.
Yes, sir.
And 3 phases are not including the plain CT part.
Yes,
3
sir.
phases are what?
Sir, parenchymal phase, arterial phase.
First is, parenchymal phase afterwards. The first phase is you inject, it goes to the artery, arterial phase.
Yes, sir.
At what time sequence you get arterial phase of CT scan?
Sir, 20 seconds.
25 seconds. Then
Yes, sir. The 45 and
parenchymatous phase.
45 seconds.
Yes. And then
65 seconds.
what phase that is?
Venous, post-venous phase.
Portal venous phase. I don't
Portal venous.
understand. After the portal venous phase, there is another phase which is known as delayed venous phase,
Yes,
where
sir.
you see the hepatic veins. So you should be very clear about what you are saying.
Yes, sir.
So you say multi-data, triphasic, CT scan, pancreatic protocol.
Yes, sir.
What oral contrast you use in this patient? For
The
this
neutral oral contrast, water we will use.
Okay. And what is the IV contrast you use?
Sir, IV. Sir, I don't know, sir.
You have to know. You're giving the patient a contrast intravenously. This is a iodine containing contrast.
Yes, sir.
Iopamic acid.
Yes, sir.
Okay.
Yes, sir.
And how this injection is done, while doing the triphasic CT scan? You just inject with a 50 syringe, or you need to have a different device?
Sir, don't know, sir.
So there is a power injector, right?
Yes.
It's something like the one you use in ICU, right? Infusion pump.
Yes, sir.
Okay. So what are the points we will try to? What are the informations we'll try to have from this triphasic CT scan?
Sir, in atrial phase, we can look for any neuroendocrine tumors, secretory tumors. And in case of in parenchymal phase, we can look for pancreatic carcinomas or pancreatic lesions in the parenchymal phase. And the portal venous phase, we can look for any tumor infiltration into the portal vein, as these tumors are more notorious towards infiltrating into the portal vein and transporting up to the heart. So we can see in the portal venous phase.
Anything else?
You see, this is a prime investigation on which you have to decide for operability, whether you'll wait, go for some other modalities, and then you proceed for upfront surgery.
Sir,
This is the only investigation.
importantly, we can see the degree of contact with the superior mesenteric vein, and we can classify the tumors as resectable or borderline resectable or locally advanced. We can classify them according to the MDCT reports.
Now you brought the term of borderline resectable.
Yes, sir.
What finding in CT scan will say you this is a borderline resectable pancreatic cancer?
Sir, borderline, resectable cancers are there should be no arterial involvement, no arterial.
I told you, how do you define borderline resectable pancreatic cancer? There are some criteria to define as per NCCN guideline.
Sir, superior mesenteric artery, if it is encased, it should be less than 180 degree. And in case of a superior mesenteric vein or a portal vein involvement, it can be more than 180 degree, but the contour of the vessel should not be altered.
Contour will be altered. If there is an impingement or CCCD, the contour will be altered. But what is important? In borderline, you should have a reconstructible vein below and above the site of obstruction.
Okay, sir. Yes, sir.
Okay. What about the celiac trunk? In definition of borderline resectable, hepatic artery, gastroduodenal artery.
Sir,
you have to give the clear definition.
Yes, sir. Sir, no, celiac trunk artery should not be involved by the tumor.
Yes. And gastroduodenal?
Sir, no, sir. Gastroduodenal also should not be involved.
No, it can. Encasement of gastroduodenal artery, but not involving the hepatic artery.
Hello?
Is taken as borderline. So just keep aside. Don't go into the controversial part. Dr. Ghosh has asked, what else you should be looking for in a CT scan, which can help you planning?
Hello?
Yes, yes. What else you see in CT scan?
Hello?
Yes, yes, you're audible. Hari Prasad.
Hello?
Yes, you're audible.
Yes, sir. Yes, sir.
What else you look for in CT scan?
Sir, any other regional lymphadenopathy is there or not?
Yes.
Sir, and ascites and any liver mets?
Yes. So there are 1, 2, 3, 4, 5, right? First of all, you have to see if the malignancy is there or not. The lesion itself you have to see, and the relation of the surrounding structures with the lesion. Okay,
Yes,
that is the first thing. Second, we'll see the vascular involvement, arterial,
Yes,
both arterial and venous. Next, we'll see associated lymphadenopathy, surrounding lymphadenopathy.
Yes,
Next, we'll see any liver metastasis present or not, or any metastasis to some any other organ or retroperitoneal metastasis or lymphadenopathy is present or not.
Yes, sir.
And we also see if there is any ascites or not.
Yes, sir.
And finally, we look into, because the triphasic CT scan, finally we look into the any vascular anomalies, particularly the arterial anomalies, and sometimes also rarely the venous anomalies. So these are the things 1, 2, 3, 4, 5 will assess from the CT scan. And based on this, we, as you said, we can decide whether this patient is having operable cancer, periampullary, or see head of the pancreas, or borderline, or it is locally advanced.
Yes, sir.
And so far borderline is concerned, nowadays borderline has been again further subdivided into borderline A, borderline B, borderline C.
Yes,
Borderline A is anatomical, as sir has discussed. Borderline B is behavior, right? The behavior of the malignancy. If it's a very aggressive malignancy, means very short history. If the patient has got symptoms like metastasis, right? So these are the behavioral things. And C is conditional. Conditional means the patient is associated comorbidity, right? Even if the patient clinically, I mean, if from the CT scan it appears to be clearly resectable, but if the patient has severe comorbidity, suppose patient has severe diabetes, right, and very high level of jaundice, or liver deranged liver function test, or COPD. So this patient is not going to have as good result as the clear-cut operable carcinoma of the head of the pancreas or periampullary carcinoma. So these things has come up: borderline A, borderline B, borderline C, right? And also the level of CA 19.9, if it is more than 500,
Yes, sir.
even in a case of city-wise, if it is resectable, so it is better to wait or go for some form of biliary drainage, right?
Yes, sir.
And wait for, or maybe pre-operative chemotherapy. Then we'll see whether this level has come down, CA19 level has come down or not. Then we can operate. Otherwise, results of these patients are not so favorable. Okay.
Yes, sir.
Okay, Hariprasad, CT scan wise report is patient has got a small periampullary lesion of 2 centimeter, double
sir.
dash sign, no
Yes, sir.
lymphadenopathy, liver is free. That is a CT report.
Yes,
What
sir.
next from your part? CT
Sir,
report has been able to pick up a small nodular lesion in the head of the pancreas.
Yes, sir.
What next from you?
Sir, if the patient's nutritional status is adequate, then we can plan for a Whipple's procedure.
You will not do further. We made 3 headings.
Yes, sir. For staging, yes, sir. For staging, we had done CECT, MDCT pancreatic protocol. Sir,
What
and,
you have done? I've given the report.
yes, sir. We can also plan for a endoscopic ultrasound.
Why?
Sir,
If the CT showed 2 centimeter mass,
yes,
no
sir.
lymph node, what further you like to have from endoscopic ultrasonography?
Sir,
That cost you
endoscopic
20,000
ultrasound.
rupees. That cost you 20,000 rupees for the investigation.
Yes, sir.
Why do you need it?
Sir, we can measure the T staging more accurately with the help of endoscopic ultrasound.
Have you seen a endoscopic ultrasound done in all your patients? You are operating in your center.
Sir, here, sir, we are doing it for free. That's why most of the patients.
It may be free, but are you doing it routinely for all patients who are being deemed operable on the basis of CT scan finding? That is not routine.
Yes, sir.
EOS is done in selected cases.
Yes, sir.
In situation where you cannot have a diagnosis of CT scan, in situation where a borderline recurrent pancreatic cancer need to have a FNA proof. So it's
Yes,
not
sir.
routine for EOS if you have been able to diagnose based on the CT scan.
Yes, sir.
You can ask for a CT chest.
Yes, sir. Yes, sir. CT
chest
thorax
metastasis.
to rule out
Okay,
lung
you see, you need not answer everything. You just don't say I'll do a MRCP in this patient. I won't agree. Because you have to proceed based on each of the findings in ultrasound followed by CT.
Yes, sir.
If I had have said your CT could not localize a mass lesion in the pancreas, so small, the next
Yes,
would
sir.
have been EOS.
Yes, sir. So for this patient, then we will further proceed with CCT thorax, sir, to rule out any lung mets.
Yes, and then the baseline investigation to assess the patient fitness for understanding surgery. Any
Yes,
role
sir.
for doing a tumor marker study?
Sir, tumor marker study is a non-specific investigation. So,
No, it is a very specific investigation here because
Yes,
Dr.
sir.
Ghosh already said.
Is a
Even if
CA19.
the CT showed a localized disease, if
Yes,
you have a CA19 being elevated more than 100,
yes, sir.
then that is one indication for doing a diagnostic laparoscopy.
Yes, sir.
High CA19 indicates a advanced disease.
Yes, sir.
It is not non-specific here. You have to do. It
Yes,
may
sir.
not be diagnostic,
Yes,
but
sir.
on the background of your imaging finding, CA19 is a investigation which is part of the workup. Dr.
Yes, sir.
Ghosh, what do you feel?
Yes, yes, of course.
Yes, sir. Yes, sir.
And what is the drawbacks of fallacy of CA19?
Sorry, sir.
What are the drawbacks of fallacy of CA19?
Sir, in case of obstructive jaundice, even in case of even if it is not malignant, then also the CA19.9 will
Yes,
be
in cholangitis may be elevated. That's true.
Yes.
But my point is, even if you have a background of malignancy, in that
Yes, sir.
case, you do a CA19.
Yes, sir. Yes, sir.
Even
But
then,
we don't take that as a diagnostic investigation.
Yes, sir.
even then, more than 100, value more than 100 is always suspicious with the malignancy. And also remember that it is more valuable, CA99 is more valuable in anicteric patient, right? In
Yes, sir.
anicteric patient, if the rise in the CA99 is more than 100, so it is more specific for malignancy.
Yes,
And
sir.
secondly, also remember that in 10% cases, CA99 may not rise because it is what is CA99?
Sir, it is a epithelial antigen, tumor marker antigen.
So yes. So it is associated with Lewis antigen, right? Blood group Lewis antigen.
Yes,
so
sir.
in 8% cases that may not be present there.
Yes, sir. Sir, and for anesthesia fitness, I will go with investigations like serum.
Okay, just leave aside. We'll baseline investigations. So now you have decided that this is the patient has got a strong suspicion of carcinoma periampullary region. What's your plan? Apart from investigation being done.
Sir, plan for Whipple's procedure or pancreas preserving pancreatic aortic, pylorus preserving pancreatic aortic.
Is there anything which still can be missed in CT scan, even a good quality CT scan? What can be missed in a good quality CT scan we are looking at? And that can change your plan.
The liver mets, no.
What liver mets?
The peritoneal deposits are.
One single liver mets will be picked up in CT scan. What liver mets can be missed? Small liver mets, less than
Yes,
2
sir.
millimeter can be missed.
Yes,
Second is peritoneal nodules.
Yes, sir.
Small
Peritoneal.
peritoneal nodule can be missed. So
Yes,
don't go with the idea that CT gives a 100% reliability for resectability.
Yes, sir.
So your approach should be either consider a diagnostic laparoscopy
Yes, sir.
and then proceed with Whipple's.
Yes, sir.
It
Yes,
cannot be Whipple's proceed in all the patients.
Sir, initially we will proceed with right subcostal, and after looking for operability signs, if it is operable, then we can convert into Chevron.
If you have the facility for laparoscopy, is laparoscopy being described?
Yes, sir. Yes, sir.
Okay,
Okay.
one very important issue is that before operating on this patient, how you
Yes, sir.
counsel the patient's relative?
Sir, I will inform them prior that there are also signs of inoperability if the patient turns inoperable.
Before that, how do you convince it's the malignancy? You have done an you have not done an
You have not-
FNAC.
You have not proved it. Nowadays,
Yes.
most of the patients are educated.
How do you counsel the patient?
Yes.
You are proceeding for a very major procedure without a histological proof. Some people will say you don't have a proof. You are telling me that you will have a very major surgery. What your counseling will be?
This is very, very important to avoid medical legal issues.
Yes, sir.
How do you counsel? That a biopsy is not required. How do you convince the patient relative?
Sir, all the imaging modalities
Yes.
and the blood parameters.
So you have to tell this patient relative that this patient having these symptoms.
Yes, sir.
On examination, you find some findings which will indicate she might have malignancy.
Yes, sir.
And on investigation, found a tumor. And usually the standard guideline now is not to biopsy that lesion.
Yes, sir.
But we have a strong suspicion of malignancy. You should always be open. You cannot be
Yes.
100% certain that this is malignancy.
Yes, sir.
Sometimes even at the end of your surgery also, you may be missing a tumor diagnosis.
Yes,
So you
sir.
have to counsel the patient like this. You are operating on imaging diagnosis.
Yes, sir.
And that is the standard of care. That you
Yes,
have to
sir.
convince them.
Yes, sir.
Yes, you'll have to say that there is 95% chance that this being a malignant tumor, only 5% chance that it could be a benign one. So,
Yes, sir.
for the sake of the patient, it is always advised and it is a standard treatment that
Yes,
will
sir.
be for the malignant radical surgery, right? Now,
Yes,
at
sir.
the end of the operation, even if the biopsy comes out to malignant benign, then it's a time to thank the God that it is not a malignant one, right?
Yes,
That
yes,
is the
sir.
way you should convince the patient's relative.
Yes, sir.
How will you prepare this patient for surgery? What are the, just mention the salient points, don't give details. What are the salient points for preparing this patient for a major surgical intervention?
Sir, serum albumin to be maintained above the normal limits, at least in the normal limits, and the albumin globulin.
Serum
ratios-
is, albumin is low. What are you going to do?
Sir, pre-operatively, I will increase the nutrition of the patient by giving TPN.
So don't jump with the idea that serum low means give albumin. Albumin low indicates global malnutrition.
Yes, sir.
So albumin low means the patient has got malnutrition and that patient has to be built up
Yes, sir.
by either giving a oral supplement or giving the patient enteral or parenteral supplement.
Yes, sir.
That is one. What else?
Sir,
Other preparations.
coagulational status, I will see the INR and prothrombin time for the coagulational status of the patient.
Yes. Deranged. What to do?
Sir, vitamin K or fresh frozen plasma transfusion.
Don't give everything in one go.
Yes, sir.
If
Vitamin
it is
K.
obstructive jaundice without hepatocellular dysfunction, simple vitamin K can correct.
Yes, sir.
So give a
Yes, sir.
vitamin K for about 5 days.
Yes, sir. 5
Next.
days I am.
Next is what?
Sir, respiratory status of the patient, I will look for the respiratory status, whether the vital capacity of the lungs are in a normal condition or not.
Patient has got associated COPD. What to do? This patient has got COPD. How will you prepare the patient? This becomes a high risk for such major intervention. But there is some
mechanical ventilation consent.
huh?
Sir, post-operative mechanical ventilation consent if needed.
No. That comes post to. I'm saying the preparation. Patient has got some COPD component. What is the pre-op optimization?
Sir,
We have not done in the what? We always ask the patient to start doing chest physiotherapy. Yes. So do a pulmonary function test. See the pulmonary reserve.
Yes, sir.
And then prepare the patient from the immediate pre-op phase. What else? Other major points. You talked of coagulopathy. You talked of albumin. You talked of respiratory. There are some more important things to come up as preparation.
Sir, patient bilirubin level should be brought down.
How? Bilirubin is 10. Do you need to brought down further or 12?
No, sir.
So talk of more important things as preparation. What about the situation that this patient may develop post-op hepatorenal failure? How to prevent that? By doing a pre-op optimization?
Sir,
What can cause renal failure in the post-op period?
sir, dehydration or
Dehydration is one. And second, gram-negative sepsis.
yes, sir.
So you have to take care. How do you hydrate this patient?
Sir,
If he is not vomiting, give oral.
or IV fluid.
How do you know patient is adequately hydrated?
Sir, urine output. If urine output
Yes.
is more.
So patient should not be thirsty.
Yes, sir.
Skin turgor should be normal. His vitals should be normal. And then you look at the objective amount of urinary
Yes, sir.
output. What about the infection component? Are these patients prone to infection in the post-op period?
Yes, sir.
Then how do you address?
Sir,
You see, examiner cannot keep on poking you.
yes, sir.
I have asked a simple question. How will you prepare the patient for surgery? So your job will be touching each of the points. You answer in 2-3 minutes, the whole points. You score. Otherwise, examiner keep on asking you every point, then it's not fair.
Sir, antibiotic, IV antibiotic, iron antibiotic should be used.
What about anemia?
There is
Sir.
nothing called higher or lower antibiotic. There is a broad spectrum antibiotic.
Yes, sir.
Okay.
And then anemia correction?
Sir, anemia correction to be done before surgery if the hemoglobin is less than 10 gram per deciliter.
So these are the components of preparation. Agreed?
Yes,
Okay. Dr. Ghosh. You can go to the
Right. So
concluding part.
tell me two or three important postoperative complications of this Whipple's procedures.
Sir, anastomotic failure.
What do you call it? We don't say anastomotic failure. Anastomotic failure, which anastomosis is going to fail?
How many anastomosis you have after Whipple's? How many
Sir,
anastomosis?
3 anastomosis.
3 anastomosis.
It's a pancreaticojejunostomy, hepaticojejunostomy, gastrojejunostomy.
Tell us about the common complication. It's not anastomotic failure. Usually we say it's pancreatic leak or pancreatic
Yes.
fistula. Right? What else? What are the
Sir,
other complications?
Sir,
Could be bleeding,
the
right?
gastric delayed gas, sir, in case of if we are not doing pylorus preserving, there are a lot of chances of gastric emptying can be
So
dumping.
yeah,
Gastric emptying delayed in gastrectomy in more or in pylorus preserving more?
Sir,
That is more in pylorus preserving.
pylorus
If you
preserving.
are doing gastrectomy, the gastric ileus is not more in that situation. It is more common in situation where doing pylorus preserving. Dr. Bosak has asked a question. He said, what is the role of ERCP and stenting in such patient?
Sir, if in
There are
case
some
of
situations.
Yes,
There are
sir.
some situations where there is a role for doing ERCP and stenting. As
sir,
free of
if in
medicine.
case the patient turns inoperable by the MDCT features, and if the patient is needing a neoadjuvant chemotherapy or the surgery anticipated time is getting delayed because of the nutritional status of the patient, then
And
we
anything
can
in relation to the LFT markers, anything in the LFT markers which can make you feel that ERCP stenting would be better in this patient? Patient has got very high bilirubin, more than 15-20 bilirubin,
Yes, sir.
associated hepatocellular dysfunction.
Yes, sir.
Patient has got cholangitis. That means
Yes,
you
sir.
need to wait.
Yes, sir. Wait.
In that case, you can drain the biliary tree.
Yes, sir.
Otherwise, it's not routine. It's
Yes,
not
sir.
any routine. There is routine pre-op biliary decompression is not recommended in patients who are operable.
Yes, sir.
Okay, that part is gone. Next, complication.
yes. Let us discuss something about, suppose it's an inoperable patient and patient is having repeated vomiting and pain.
Yes,
So how would you treat this patient?
So
that
by
means palliation. Dr. Ghosh has declared this patient is clinically inoperable based on the investigations. Now patient is having intractable vomiting and severe pain.
sir, bypass surgery we can plan.
No, you can specifically answer. Which bypass? Bypass means what? Biliary bypass? Or gastric bypass? Which one?
Sir, the triple bypass we can plan. Choroidocojejinostomy, gastrojejinostomy, and pancreatic.
So if the facility is available, we can go for endoscopic stenting in the form of duodenal stenting and in the form of recipient stenting.
Yes.
If the facility is not available, then we'll
Particularly, but if the patient is more sick,
Yes,
if the patient is more sick, you consider doing a non-operative bypass.
Yes, sir.
Okay. And triple bypass is not pancreaticojejunostomy. That is not the part of triple bypass.
Yes, sir.
That triple bypass is said to be jejunojejunostomy.
Yes, sir.
Okay, hepaticojejunostomy, gastrostomy, and jejunostomy is taken as a triple bypass. We don't do a pancreatic decompression for a palliative bypass.
Yes, sir.
And what about pain? For pain, what will we do?
Sir, in case of a palliative patient for pain, we can start on morphine, and we can also plan for celiac plexus blockade. Sir.
Right. So either with the oral supplementation or IV supplementation with the analgesics do fine, then it's okay. Otherwise, we can go for celiac plexus block.
Yes, sir.
So for any malignant pain relief, you should follow the WHO ladder of pain relief. Okay, there's a
Yes,
WHO ladder of pain relief. Start with paracetamol and then
Yes,
go to the NSAIDs
Yes,
and then narcotics.
Yes, sir.
And if not relieved, you can go for some interventional procedure.
Yes, sir.
Dr. Ghosh, any last question?
Yes.
We have done 9-10.
No, I think reasonably we have covered all the areas of obstetric jaundice. So I want to emphasize on one thing, that history and clinical examination is always very, very important.
Yes, sir.
In your DNB or MS examination. So please pay attention, as Professor Saha has said. These are your opening sessions. So if you do well in that portion, so we can go on to the next, like investigations and management. So,
Yes, sir.
and everything, whatever you said, has to be, I mean, rational, logical, and scientific, right?
Yes.
So that things you should keep in mind.
Yes, sir.
Yeah, thank you.
Thank you so
Hari
much.
Prasad. Thank you.
Thank you, sir. Thank you, sir.
Thank you.